when we get to the airway, the applied anatomy is the terms of compromising of this airways, nasal cavity, oral cavity, pharynx, larynx, trachea, and principal bronchi. And this is a palatopharyngeal arch and glossopharyngeal arch, and these are palatine tonsil, and these are the masseter muscles. And if we come to this cross-sectional view, this is the nasal cavity, and this will be our palatine, and this is the oral cavity and tongue. This is the pharynx and epiglottis, and this is the larynx, which we see the vocal cords here, and this is the esophagus. When we come down to this oral cavity, after next is that we see this larynx, tracheum, principal bronchus, and bronchioles. Now, for assessing the underlying causes for airway control, it is temporary support or permanent support. Generally, we use temporary support for airway control in anesthesia and the presence of irreversible intrinsic lung and neuromuscular disease, protection of airway due to depressed mental status, and presence of irreversible upper airway pathology or patient care. We need to transport CT or MRI scanning, or significant comorbidities or aspiration potential and increased respiratory secretions, and hemodynamic instability, whether due to cardiac or sepsis causes, or renal or acute liver failures. In permanent supports, generally where advanced intrinsic lung diseases or neuromuscular diseases, where we see the permanent support of artificial ventilation is needed. And when comes to duration of intubation, if we want for prolonged duration, then nasal is avoided, and oral is more better than this nasal. When come to pathophysiology of respiratory failure, basically we have just two types: hypoxic respiratory failure and hypercapnic respiratory failure. In hypoxic respiratory failure, we can use different non-invasive deliveries which can be used, and the severity of hypoxia and presence or absence of underlying lung diseases will define which gadget we should use for this respiratory failure. In hypercapnic respiratory failure, where non-invasive device is more good choice, and where it is BiPAP. And when I'll come to the degree of respiratory distress, where we see the respiratory pattern, accessory muscle usage, and respiratory rate. When respiratory rate is greater than 30 and usage of accessory muscles and his respiratory pattern is difficult, then we need non-invasive support or intubation. A need of artificial airway when the tongue or epiglottis is fallen back to the posterior pharyngeal wall, or nasopharyngeal airway when better tolerated. And in pulse oximeter, when oxygen saturation is less than 92% with FiO2 of fraction of oxygen with 60 to 100%, then we need to intubate, or we should see any immediate reversible causes that can improve the ventilation. When coming to arterial blood gas, when pH is less than 7.3, we need more of non-invasive support or intubation is required. By this above assessing of the patient, whether which type of respiratory failure and degree of respiratory failure, then the clinician will decide which type of ventilation the patient needs. If we come to the upper airway obstruction, this is the main pathophysiology that we see. We see this weakness of glossopharyngeal muscles, which leads to depression of tongue and touching to the posterior pharyngeal wall. This is mainly of upper airway obstruction. So the airway patency is lost. Then clinically, how can we can see that patient upper airway is long? We can see tracheal tug or intercostal usage of muscles, and paradoxical breathing or restlessness, noise and snoring is thin. And even if we do ambu bag, where the reservoir bag doesn't fill and patient is desaturating and cyanosis. And how can we prevent this upper airway obstruction? When we don't have gadgets around us, even that we can do, because of just simple of this head tilt. If you do head tilt towards up, and then this airway become patent, or just jaw thrust holding at the angle of mandible and just lifting it up will causes this opening of airway. Or this is a triple maneuver where we lift up the jaw at the angle of mandible and we open the mouth to the opposite direction which we stand. these are the simple basic techniques of 3 airway maneuvers, which we can make upper airway patent. With equipments, generally we have oral and nasal airways. And this is a method how we introduce to select the size. We have different sizes based on their color codings. Generally in adult females, we use green or yellow color. It is size 1, 2 or 3. Or in adult male, yellow and red, 3 or 4 generally. How to measure this size? Just from the angle of mouth to the angle of mandible. Externally, we can place slices and we can select the appropriate size of oropharyngeal airway. And this is the method of incision. It is according to the natural anatomical shape we can introduce in this way. And when come to this nasopharyngeal airway, and this is a nasopharyngeal airway, where we measure the length of the nasopharyngeal airway. Ideal to the patient is that from the nose of the tip to the tip of tragus. This is the type of selection, and the bevel should be towards the nasal septum. And we should apply jelly and place along the curve of the nostrils. Now coming to the indication of intubation, we have many indications and relative contraindications and adjuvants. When coming to indications like airway in trauma, burns, and loss of protective reflexes, and pulmonary toileting, and respiratory failure, and CNS causes like cerebral due to overdosage of any drugs, or CNS infection like meningitis, or trauma, whether EDH or LDH, based on the patient GCS, and spinal cord trauma, and chest wall deformities with severe kyphosis, and upper airway obstructions like croup and epiglottis, and lower airway diseases like bronchiolitis and asthma. And the adjuvants in treatment and evaluation of pathological conditions like neurological resuscitation, where hyperventilation is seen, and shock to decrease work of breathing. In any drug overdosage, just to airway protection and gastric lavage and peritoneal lavage. And in CT and MRIs, where the patient is not cooperatable and we want to secure his airway because of its low GCS. And relative contraindications like spontaneous breathing with adequate ventilation. Concurrent that intubation and mask ventilation might be unsuccessful, and major facial and laryngeal trauma, upper airway obstructions. We want to assess the airway before before we want to intubate. The simple thing that mnemonic we can see is that lemon. Look externally the face, any trauma or any difficulty, and evaluating as simple as 3-3-2 rule. The incisor internal distance between 3 fingers, and hyoidmental distance is 3 fingers, and thyroid mouth distance is 2 fingers, and Mallampati scoring of 3 fingers, or obstruction or peritonsillar abscess, and neck mobility. We have other just assessment also for difficult intubation. This is the lemon. Look, evaluate, Mallampati, obstruction, and neck mobility. For a difficult bag mask ventilation, radiation, obstruction, obesity, OSA, or mask with seal, or male patient, and Mallampati of grade 3 and grade 4, or age and neck trauma. And difficult for intubation with laryngeal extraglottic devices like LMS. It is like we got rods, restriction, obstructive airway, distortion anatomy, and shorter of thyromental distance. Difficult surgical airway, where previously surgeries or mass or anatomical difference or radiation and tumors. And when we come to this Mallampati grading is the basic airway assessment, where the oropharyngeal and tongue cavity is assessed. Class 1, where we can see the uvula, soft palate, hard palate, and this facial pillars. And in grade 2, we can see the uvula, soft palate, and facial pillars. Only fasces are seen, and these pillars are not seen in class 2. Class 3, only the base of uvula is visible and soft palate is visible. We don't see this these pillars visible, and foci pillars we can't see. In class 4, only hard palate is seen. Class 3 and class 4 are meant for difficult intubation. And this is Kroman-Lekan grading, where we intubate after when we do scopy, direct scopy, then based on visualization of cords, it has been graded. Here we can see total epiglottis and entire aperture of this vocal cords. In grade 2, we have just arytenoids of the scene. In grade 2 also, grade A, B, and C, A, B, where cuneiform only is seen it in grade A, and posterior part of glottis is seen in 2B. And visualization of epiglottis, only epiglottis is seen. Here we can't see any vocal cords, any part of vocal cords. That is grade 3. And we don't even see this epiglottis in grade 4. Generally, to intubate to pass tube also, this both are difficult. This is another way of assessing this difficult airway intubation. Basically, the length of upper incisors are overriding the maxillary teeth, which will be difficult for intubation, introducing the laryngoscope, where inter-incisor distance is less than 3 and thyromental distance is less than 7 and neck extension is less than 35 degrees and sternomental distance is less than 12.5 centimeters and with full extension of head and mouth closed and the narrow palate, less than 3 fingers breadth of mouth opening, and Mallampati score grading of 3 and 4. And this is the stiff joint syndrome, which we commonly see in diabetic patients with all joints are due to deposition of glycopeptides, it becomes stiffened joints. This is a common we see prayer joint sign, where this all his joints will be not able to approximate. Then it is called as positive prayer sign, is where neck mobility will be difficult. By assessing all these things also, we can't say it is as easy, difficult or difficult intubation. Even though if we assess all these things and if it is not there, even though it can become difficult intubation. Then what are the challenges that we face during intubation? One, potential risk of aspiration during rapid sequence induction. So clearly, generally we avoid clear liquids for greater than 4 hours and particulate or solids for greater than 8 hours in elective cases. But in ICUs, it is not possible. And acute injuries with sympathetic stimulation and diabetics may have prolonged gastric emptying. Though we waited for 8 hours, they can have a risk of aspiration because of prolonged gastric emptying time. And potential of hypotension, cardiac dysfunction, hypovolemia, and sepsis, which patient may crash during intubation. And in such condition, we may use considered awake intubation or topical anesthesia to compromise this hemodynamics and even make to better. And in any organic failure and renal hepatic failure with the limited medication that we can use in this such condition. To face that challenges, we should be prepared. So this is a simple mnemonic this we have back people. So prevention of aspiration is one of the main concern. So our section should be ready and bag ventilation mask to maintain the safe period. And we should have good access to vein if we get hypotension to treat it emergency and to give medication. To get our team prepared for difficult airway and patient positioning is important, and checking of endotracheal tube and checking of it cuff and syringes, and see that oxygen and oropharyngeal areas are prepared. And pharmacy means all induction agents and neuromuscular agents. Generally in ICU, we don't want to just intubate and extubate at the same time. So we should be prepared for the next 24 hours. So we should load all neuromuscular agent of our long acting also should be ready. We should prior only check this laryngoscope blades, whether working or not. And then we should evaluate, as we said with the lemon mnemonic, look for any obstruction of thyromental distance or interincisor distance and neck mobility. And this is a laryngoscope. We have different types of handles and different types of blades. This is a short handle, which we use in obese. This is a pediatric handle, which we will use in less than 20 kgs of mass. And this is adult laryngoscopic handle. And this is a Miller curved blade. And this is, Macintosh curved blade. And this is Miller straight blade. And while selecting the numbers also, we can identify here the numbers. Just immediately, if we ask adult, give 3 blade, we can see here the markings, which blade to be selected. And this is the Miller's also, all sizes available from 0 to 4. Here also in Macintosh also, we have 0 to 4 blades. This is the endotracheal tube. We have different parts of the endotracheal tube. This is called bevel. This is Murphy eye. This is cuff, and this is vocal cord guidance. After passing the tube, we should see that this mark is just passed opposite to the vocal cords, and these are the markings. This is the pilot balloon, and this is the adapter, universal adapter. Then how to select the size of ET tube? In pediatric case, we have a formula for uncuffed tube, age by 4+4. Generally, we use for newborns is 3 or 3.5. For cuffed tubes, age by 4 plus 3.5. It is classically for greater than 8 years and less than 1 year. Generally, to remember, for an adult female, 7 to 8 size, and adult male, 8 to 9 size, and for pregnant women, 6.5 to 7.5 men. And for age less than 12, by simple this calculating this formula. Then where do we fix the tube? Generally, the depth, ET size into 3. Whichever the ET size, if you select, into 3 is the basic formula to know where we should fix the tube. And auscultation is the best sign to see that both lungs are ventilating. This is the pediatric age group which laryngoscope we should select. For premature or newborn, Miller's 0 size. For 1 month to 2 years, Miller's 1 or 2 size. From 3 to 6 years, Miller's 3 size or Macintosh size 1. 6 to 12 years, Miller's 2 or Macintosh 2 blade. Or greater than 12 years, we can use Macintosh blade 3 size. And this coming to face masks, we have different types of face masks like anatomical face mask, ambu transparent mask, or Rendelband source mask. This is the black color which we commonly see in ICU. It is an anatomical mask. These are a reusable one, and this is latex or a transparent ambu mask with this air filled. This is Rendelband mask, which are for pediatric cases of less than 2 years. Generally, we use this Rendelband mask. Now, coming to face mask and ventilation techniques, where the patient will die because of not ventilating, not of intubation. So we should be more concerned about ventilating the patient rather than intubating the patient. So the techniques are first sniffing position. If C-spine is okay, this is the most remembering point that we should see in ER and ICUs because of traumatic cases. And this is called CE technique, where our thumb and index is above the mask and it is compressing to make a tight seal, and the handle E. E stands for the grip, where the angle of mandible that we hold. We should not touch his soft tissue where our bony prominences, we should hold it. This is one hand technique, and 2 hands where it is when it is difficult to ventilate, we can use 2 hand technique, or this is hand grip wise technique, or and CE plus E, both combined technique. These are 4 types of techniques of hand grip that we use. If in ER we get an RTA case, unless it is proven that we should think as C-spine injury is there. In such cases, manual inline stabilization technique is that we should use prior to intubation. This is the image where we should not turn his head to right or left. We should make immobilized collar. And if we want to shift also, such thing, paddle should be kept so that his head is not tilting. And because C-spine injury is more common and seen in polytrauma cases. How to suspect difficult mask ventilation. This is another mnemonic we have. This is male gender and mask seal with affected by either bead or being edentulous, or Malampati grade 3 or grade 4, or mandible protrusion. Age is greater than 60, then they will be edentulous, and history of snoring or obstructive sleep apnea, or weight BMI greater than 35. This is another thing where we saw BMI greater than 26, obese, bed or edentulous, snoring, and elderly. These are the conditions where we commonly see of difficult mask ventilation. Then after holding the mask, we should pre-oxygenate. What are our 3 goals to pre-oxygenate? To achieve 100% saturation prior to the procedure, and denitrogenation of residual capacity of lungs and maximize the oxygen storage, and denitrogenation and maximal oxygenation into the bloodstream. This pre-oxygenation allows us this safety buffer during hypoventilation and apnea. It extends the period of safety of apnea, which defines as saturation level 88 to 90 when we allow to placement of airway. Below this level, the oxygen saturation can decrease critically to less than 70 within a moment. This pre-oxygenation device, we have two types, unsupported ventilation or pressure-supported ventilation. Unsupported ventilation, like simple face mask with reservoir or bag mask ventilation, or non-breathing or nasal cannulas. And with the pressure support ventilation also, we can give pre-oxygenation like continuous positive airway pressure, or BiPAP, bilevel positive airway pressure, or high flow nasal cannula, or helmet delivery positive pressure devices. After pre-oxygenation, then induction agents. Generally, we use 3 or 4 induction agents. This sodium thiopentone, generally we don't use in ICUs. It is seen in OTs where 3 to 5 ml per kg. These drugs have some side effects like profound hypotension or hypovolemia due to histamine releases, and those should be decreased in both renal and hepatic function. And etomidate, it is 0.1 to 0.3 mg per kg IV. It is more hemodynamically stable drug, which we use generally in ICUs and cardiac OTs. We can lower the doses in elderly and hypovolemic patient. It is more hemodynamically stable when compared to other drugs. And this causes acute adrenal cortical deficiency. And Propofol, 2 to 3 mg per kg weight of dose. It also causes hypotension, and especially in systolic heart function disease, and even bradycardia, we should be aware. In heart blocks, the patient with heart blocks, we should be careful while giving Propofol. And ketamine just 1 to 4 mg per kg of IV, and 5 to 10 mg per kg of IM, where it causes sympathetic stimulation, where we required atropine or glycopyrrolate to reduce the stimulation caused for salivation, and midazolam for preventing of ketamine-induced delirium. And it should be avoided in a patient who lost autoregulation or closed head injuries, because it increases the ICP. Then comes to neuromuscular blockage. We use in rapid sequence induction, we use scoline and succinylcholine and rocuronium, where succinylcholine 1 to 2 mg per kg IV. If we don't have IV access, we can give up to 4 mg per kg IM. This should be avoided in a patient with known case of malignant hypothermia, or greater than for 24 hours of burn patient or traumatic injury, or upper motor neuron lesion, or pre-existing hyperkalemia in CKD patients. And this rocuronium, it is 0.6 to 1.2 mg per kg. High dose is required for rapid sequence induction. It is more hemodynamically stable agent, and only 10% of renal elimination. All these side effects of succinylcholine we overcome with rocuronium. And this when come to this rocuronium, 0.1 mg per kg, it is hemodynamically stable, and it is also 10% renal elimination. And cisatracurium, 0.2 mg per kg, they have mild histamine release when compared to atracurium, or this degrade by Hoffman elimination, and it doesn't affect on renal or hepatic function. These two are short acting, which we use in rapid sequence induction, is succinylcholine or rocuronium. These are long acting agents which we don't use as electively. For maintenance, we can use rocuronium or cisatracurium. And positioning of patient is more important while intubation. The main aim of positioning of this patient is to bring all these 3 axes into one line: oropharyngeal axis, pharyngeal axis, and laryngeal axis. And if we keep extension pillow or headrest, then this pharyngeal axis and laryngeal axis will come into one line. If we cause next step is that extension of head, it causes atlantoaxial joint flexion. It causes oropharyngeal axis towards the pharyngeal axis. The main aim is that to bring this all 3 joints approximately in the same line. And this is classically called as a ramp position, which we generally use in obese patient, where obese patient are difficult intubation and ventilation, where we keep 2 sandbags or pillows and make the ramp position. so that the external notch, external part of ear and external sternal notch will come in inline, so that we can get all these three axes into the same line. This generally we use for obese patient of greater than BMI of 26 kgs. Then when come to intubation technique, generally we should hold in right hand, whichever the hand, dominant hand, we should hold the laryngoscope in left hand, and we should introduce at the right angle of the mouth with a cuff blade. We should move away our tongue in the visual field. Then at the edge of epiglottis, we should hinge, and as a leveler, we should pull up the handle so that we can see the vocal cords. Then we can pass. If when we come to this Miller blade, we should keep above this epiglottis. Before epiglottis, just we will hinge in this Macintosh blade. With the Millers, we should cover the epiglottis also. Generally, in pediatric cases, we do that in less than 2 years. And after this placement of tube, we should be confirmed that placement of tube is much more important after intubating. Direct visualization of cords or fogging or humidity in endotracheal tube. If we have end-tidal EtCO2, then to maintenance after greater than 5 breaths. If low cardiac output status, there may be decrease of delivery of CO2. Or refilling of self-inflating bag like AMBO or brain circuit of greater than 5 seconds after the endotracheal intubation, or symmetrical chest wall movements, or bilateral breath sound by auscultation, or maintenance of oxygenation by pulse oximeter, and absence of epicaustic auscultation during ventilation. These are the signs of confirmation of placement of ET tube. You should be more confident after placing the tube. If you have any doubt, you should recheck it. When come to rapid sequence induction, we use in ERs and ICUs this rapid sequence induction, pre-oxygenation for 3 to 5 minutes prior to induction to increase the apneic time to wash out the nitrogen and premature desaturation. Then cricoid pressure we should apply prior to induction until the confirmation of placement of tube. Generally, we use succinylcholine 1 to 2 mg per kg of IV, which gives us intubation condition within 30 seconds. In rocuronium, 1.2 mg per kg to achieve intubation condition within 45 seconds. Other muscle reluctant, we don't use for rapid sequence induction. We should not mask ventilate after induction. That is the main step of rapid sequence induction, which potentially cause inflation of stomach and which leads to aspiration. This is a technique that we can see how to apply the cricoid pressure. Mainly the only thing that this cricoid is a complete ring so that it can compress the esophagus. If you see this is the thyroid cartilage and this is the cricoid cartilage. If you apply pressure on cricoid cartilage, you can see the compression of esophagus. So that it says that prevention of any contents coming from esophagus to the oral cavity. And the complications of intubations are like malpositioning of tube, placing of a tube into esophagus, or trauma while handling the laryngoscope, or aspiration, and any physiological reflexes, or malfunctioning of the tube. That's why we should check the cuff and tube before placing it. While tube patient, whether you placing in esophagus or it is more anterior into the right lung, or malfunctioning of tube. And following extubation also, the airway trauma, physiological aspect, and laryngospasm and aspiration. These are the common complications that we see during intubation and extubation process. And this is the difficult airway algorithm that we should be aware when we are intubating. First, to assess the difficulty of cooperation and consent is one of the important things before intubation, and difficult mask ventilation, or difficult supraglottic airway placement, or difficult laryngoscope, or difficult intubation, or difficult surgical airway access. This is all by this Lemon scoring and what we have discussed prior. And we have an algorithm which we should follow while difficult. In case of awake intubation, if you are awake intubation and non-invasive, if we are success, it is okay. If we are failed, then we will cancel the case. In if we are feasibility with other options of supraglottic airway devices, then we will go for supraglottic. Or if we failed both by supraglottic or invasive, then we have invasive airway access like cricothyroidotomy or tracheostomy. And intubation after general anesthesia, direct with the general initial attempt, we are successful, okay. Then if you are not unsuccessful after the induction, then the first step is that we should call for help, or we should make patient return to the spontaneous circulation or awakening the patient. This call for help, you should not delay. Then face mask ventilation. Whether we should see that we are ventilating the patient or we are not able to ventilation. If we are able to ventilate, or if you are not able to ventilate. If we are able to ventilate, it is a non-emergency, and we can awake the patient and we can cancel this and we can reassess. Or another try of next expert, so that successful intubation. If we are failed, then we can go with invasive airway approach. Or if you are not able to adequately ventilate, then we should try for supraglottic airway devices. If you are able to ventilate with supraglottic airway devices, then we should go to non-emergent, like again intubation or invasive lines. If you are not able to ventilate with supraglottic airway device or intubate, then it is an emergency pathway. Then we should, when we are failing for supraglottic airway or ventilation, then emergency invasive lines like cricothyroidotomy we should see. Then the alternate methods for intubation rather than this classical is blind nasal intubation, and we have different gadgets for helping of this difficult airway access. This blind nasal intubation, bleeding may cause problem with subsequent attempts, and it is contraindicated in patient with facial trauma due to cribriform plate or CSF liquid. Generally, we should avoid in immune compromised patients like bone marrow transplantation, because if you damage this cribriform plate, directly the patient will land into meningitis. And this Escherman stellate and fiber optic bronchoscopy and laryngeal mask airway disease and light band and retrograde intubation, surgical tracheostomy or combi tube. These are the different things we are going to discuss. This is Escherman stellate. Generally, we use for in grade 3 to achieve after direct laryngoscopy we perform. They place Escherman tube directly into the trachea. We will feel the rings of trachea. Then we can thread off 7 size or 7.5 size tube to place it. Then fiber optic scopy, it is essential to do bronchoscopy. And in difficult intubation, also we can use a pre-filled syringe to the bronchoscopy. Generally of above 6.5 size, any tube will be fixed. We can use in supraglottic airway devices also to exchange this supraglottic airway and put a tube. And these are the different types of laryngeal airways that we see. This is a LMA classical of first generation. It is made up of silicone. It is originally of only the problem is that with increased cuff pressure is one of the disadvantage. This is LMA unique. It is first generation. It is polyvinyl. When compared to cuff pressure, it is low. And LMA fast track, we have it is polyvinyl and it is self-curved. So self-curved will increases the ease of intubation, and this is flexometallic flexible. This reinforcement wiring will be there, and ProSeal, which have additional cuff secretion, and we can have a gastric port also to empty. And this is LMA Supreme, that is also second generation, where a disposable version of ProSeal LMA is seen. And these are the techniques. This is the technique how to place an laryngeal mask airway. Just the pen holding technique, we'll call it. We should press along the palate and pass along till our finger goes where we see an obstruction. Then we should inflate the cuff and we should ventilate and see it. This is light band. It is a transillumination in trachea with light at the distant end, where trachea is not visualized directly. Just we can see the light in the upper side, and it should not be used in cases of tumor or trauma or foreign body or upper airway, where minimal complication is expected, like mucosal bleed. 10% of failure rate of the first attempt is seen, and the experience hands also with this light band. And this is a retrograde intubation. where we puncture this cricothyroid membrane and retrogradely pass the tracheal wire, and then we will intubate this. This is rarely used nowadays because of advanced gadgets. This is a combi tube. This is the emergency airway that is mostly used by paramedic and emergency physicians when the failed endotracheal intubation, where ventilation is confirmed through blind blue tube. This combi tube, we have seen, this is the distal cuff and the proximal cuff. We will have a next picture where the distal cuff will be in the trachea, and the proximal cuff will be in the oral cavity. When the ventilation is confirmed with the white clear tube, we have two tubes. One is blue color and one is white color, and we can use this fiber optic exchange also with this combi tube. And the only problem is that it is a blind technique, and it is oral trauma is more with this combi tube. Then this is a tracheostomy. Tracheostomy means it is the placement of tube between second and third tracheal rings. This is the technique generally we use where we introduce the blind needle between second and third tracheal ring. Just after aspiration, we get in air. Then we will confirm that it is in tracheal. Then we have a pre-filled dilator, which we use. After the dilator, we have a specific device as Union, which we use for dilatation of this tube. And then we will place the tube. And this is the emergency cricothyroid method. It is a commercially pre-filled kits are available, where this cricothyroid membrane, it is between the laryngeal cartilage and cricoid cartilage. We see the membrane where directly with this filled, we can, if we press on this cricothyroid, if we go away this cricothyroid membrane, then the air be filled in this syringe. It is more safety device which we have, and it is very easily to perform in emergency situations. And this is the topic. Then we go to the assessment of questions which we talk about this session. What is the most helpful to determine the need of intubation? ABG, it is clinical assessment, or lung auscultation, or pulse oximeter alone, or testing of gag reflex.
Yeah, participants can chat in the box, or they can text in the chat box, or they can answer also in the chat box. Yeah, Dr. Hitesh answered B. Then Devi answered as ABG. Ruthlal B. Aishwarya B. You can, there is no, I won't announce the name, so you can just text the answer. That's okay, no problem. Okay, I think now everybody stopped answering, I guess. Okay, ABG, then B. One more. If one more answer comes, then Sudheer will tell the answer. Okay, that's all. Others you can guess. There's no negative markings, or there is no marking itself. Yeah, can we go ahead? That's Sudheer.
Mainly, clinical assessment is more important than any other thing to determine intubation. If patient is unconscious and is not maintaining his airway, going for an ABG is a wasting. Or based on only the pulse oximeter, if his respiratory rate is more than 30 and is agitated due to his hypoxia, where we are seeing the saturation is okay, it is 90, then we can't intubate. So clinical assessment is more important than any single investigation that we decide on intubation.
If anybody has doubts in that, maybe you can raise your hand or you can switch on your mic and you can ask question. Okay. Yeah, we'll go to next. Can we go to next one?
Yes, sir. A decision to intubate should be based on which essential criteria? A, failure to maintenance or protection of airway, failure to ventilate or oxygenate, or anticipated clinical course of deterioration, or all the above.
This, I think everybody has got it.
Yes. This, all the things are okay for all. Answer is all the above. Where whenever the airway is not protected by his own, we should intubate. Whenever we are not able to ventilate or oxygenate both, we should. If patient is in hypotension, severe hypotension, where pH is less than 7.3, then if we are expecting the patient might collapse in next half an hour or 1 hour, then also we should intubate. All this criteria is in. This another thing, identification of correct sequence, both ABC, A, preparation, pre-oxygenation, pre-treatment, paralyzing with induction, placement of tube, positioning, and post-tube management, or preparation, pre-oxygenation, pre-treatment, positioning, paralysis with induction agent, placement of tube, and post-intubation management. Preparation, pre-treatment, pre-oxygenation, paralyzing with induction agent, placement of tube, position, post-tube management, where preparation, pre-oxygenation, pre-treatment, paralyzing with induction agent, positioning, placement of tube, and post-tube management.
Five members have put up their answers.
Because sequence of steps are more important in emergency situation.
Absolutely, the presence of mind should be there, and even in your sleep, you should be able to remember the sequence. So most of them answered B. There are two people answered D.
Shall we go with the answer system?
Yeah, I think now
the answer is most of the options that we got is B and D. The correct answer is D, where preparation is more important. Getting all the gadgets, suction be ready, oxygen cylinder, everything make ready. Then pre-oxygenation, then pre-treatment like induction agents. Next, paralyzing with the induction agent. Then positioning. Here, positioning is not there in this B. After positioning, placement of the tube. Then post-tube management. The correct answer is D.
Anybody has any doubts? You can text in chat box. Okay.
Which of the following is correctly paired? We have shown some mnemonics, and this Rod's mnemonic for difficult cricothyroidotomy, and this is Mons mnemonic for difficult extraglottic airway device placement, and Lemon it is for evaluation of difficult airway direct laryngoscopy, and short mnemonic for difficult placement of extraglottic airway devices, or HELP mnemonic for difficult cricothyroidotomy.
Some answers are coming now. B, C, C, B. That's all. So you want some more time to answer the question? We'll wait for another 10 seconds. See.
We go outside.
Yeah, we'll go ahead. We'll go ahead, Dr. Sudheer.
This is a mnemonic for difficult intubation. This is the lemon. Look, evaluate 332 Malam patti and obstruction of obesity or neck mobility. This is for intubation. And for difficult bag mask ventilation, like Roman, like radiation, obstruction and obesity and OSA, mask seal or male patient, Malam patti or aged, and difficult LMA or extraglottic airway device then it is rods, restriction, obstruction, distortion of anatomy or shorter thyromental distance. Then difficult surgical airway like cricothyrotomy or tracheostomy is smart. Previous surgeries, mass anatomy, different anatomy or radiation and tumor. You can safely manage the airway in a patient with suspected C-spine injury by using a chin lift, direct tongue depression with laryngoscope, or head tilt, jaw thrust, or none of the above. This is one of the important thing in RTA cases when you suspect cervical spine injury.
Answered E. I think out of all these questions, this is the most, I think the easiest question is this only.
The answer is jaw thrust. The simple jaw thrust we can use in suspected of cervical spine injury, where just lifting the jaw itself is enough without any mobilization of the C-spine. When using a rapid sequence in intubation to placement of endotracheal tube, which of the following medication should be used for paralyzing? A. Tomdate, B. Cisatracurium, C. Rocuronium, D. Vecuronium.
Someone answered C. This at least I'm expecting everyone to answer, at least attempt. B. B. Someone answered D. C, D, D. No. Except A, everybody has answered. Everybody has taken all other options.
Shall we move, sir?
Yeah.
The answer is C, rocronium, where A is etomidated is not a paralyzing agent, it is induction agent, and where this cisatracurium and rocronium are intermediate acting drugs. So we don't use for rapid sequence induction, we use for maintenance. The answer is rocronium. Succinylcholine and rocronium that we use in rapid sequence induction, the paralyzing agent. And these are the references for the above topic of difficult airway. And thank you. Now I am handing to my moderator, Dr. Ravishankar, sir.
Yeah. Thank you, Dr. Sudheer. It was a nice presentation with a very understanding pictorial diagrams. I would like to summarize with a few words, like, in our day in and out practice in ICU and emergency, intubation, we can say it's like bread and butter of ICU and emergency nurses. So it's very essential to know the anatomy and applied physiology of oropharyngeal tract. Then you should be well versed with the pharmacological agents that you are using and the gadgets that you are using apart from the regular laryngoscope and other agents. The emergency intubation trays, sets, and you can customize yourself based on your needs, how to maintain the difficult airway sets. Difficult airway algorithm will guide you what are the steps that you are supposed to take, but you can customize according to your facility and resources that your hospital is having or your unit is having, and you can customize your difficult airway algorithm based on that. And thank you, Dr. Sudheer, for the pictorial diagrams. If any questions, we can answer through the chat box.
Thank you, sir.
Any questions from audience? If not, thank you, ISCCM, for giving us an opportunity to interact with the students. And I thank all the participants for their active participation.